Tonight, what we're going to be looking at is basically some of the other opioids, and just very briefly mention some other drugs, or I think there's probably only one other drug. So the aim to broaden clinical competence and understanding of pharmacological strategies, including the modes of delivery, which is an important aspect of both inpatient and home-based palliative care. To have some sort of understanding about conversion rates. Now, last year in 2009, there were 3 articles in the Journal of Pain and Symptom Management, basically one following another on conversions. And basically, the upshot of those articles was that it's not an exact science. So even though we've talked, changing from morphine to oxycodone is 2/3, that may not be right for a particular patient. So a lot of it is trial and error, but you need to be aware that you don't give the same dose of a potent opioid, like changing from morphine to hydromorphone and give the same dose. You'll run into trouble. Determine the appropriate route for administration of those drugs. To become familiar with syringe drivers and pumps used in palliative care setting, and just to identify other modalities that are effective for management of pain. But we're not going to go into that in any detail. So just recapping, sort of some of the stuff we looked at last week. Last week we looked at morphine in quite a lot of depth. So you've got opium or papaverine. You've got the naturally occurring opium alkaloids from opium, and they're codeine and morphine. And codeine is just methyl morphine. You've got the semi-synthetic drugs that we use commonly, so oxycodone, which is used more and more, hydromorphone, which as I said, we're probably going to be seeing more of hydromorphone as well. Buprenorphine, the Norspan patch, and although it's not licensed, Norspan's not licensed to be used for cancer-related pain, some of the cancer patients are on it. Remember, it's that preparation I'm talking about, not the drug, the preparation, so Norspan. And the synthetic drugs. So levorphanol we don't have, pentazocine we don't use, pethidine we don't use, basically because of its sealing. Fentanyl we certainly do use as the Duragesic patches, and we can use it subcutaneously as well. Sufentanil I haven't used for many years, but it's an alternative for someone when they don't tolerate morphine or morphine-like opioids, and you're having trouble getting adequate doses into the patient, say in a syringe driver, because it's about 10 times more potent than fentanyl, but not a drug that's commonly used anywhere around the city. And then the diphenylpropylamine group, of which methadone, I guess, is the best known. But that also includes dextropropoxyphene, and a drug that, once again, I haven't used for many years, dextromoramide. I think the last time I used dextromoramide is when I don't even know if it's still available. It's probably not. I used that in New South Wales probably close to 20 years ago. So, there is that good choice of drugs. So if we just go look at them, the drugs that we do use, oxycodone's been around for a long time, and it's a mu agonist as well as a kappa agonist. And the thing about it is it's got good oral bioavailability. So once again, I think if you recall from last week, people say morphine's not well absorbed. That's not correct. Morphine is well absorbed, but its bioavailability is around about 30 to 35, maybe 40%. So when you compare it to oxycodone, its bioavailability is much worse. So approximately 1.5 times more potent than morphine on a milligram for milligram basis. It has no clinically significant metabolites as morphine does in terms of side effect profile, and is available, of course, in immediate release and controlled release formulations. So it's sometimes called an overlap opioid. So if you've got someone on simple analgesics, or maybe they've been on codeine and you're thinking of that next step up in terms of tablets, then endone's been around for years and years, and we're all familiar with the use of endone. So a 5 milligram dose. There's no dose ceiling like the same as morphine, so you can use buckets of the stuff if it's doing the job. It has a short half-life similar to morphine, and that it is available in liquid as well. So the common preparations, obviously endone and the oxynorm group. Controlled release, the OxyContin tablets, which is this so-called acrocontin delivery system. It has a biphasic half-life, and so a patient who's got a bit of pain and they're due to take their OxyContin, they may actually not need to take an immediate release drug with it, because they actually get a small peak in about 40 minutes or so, and then they get the other peak at about 10 hours, I think. 6 hours, sorry. Analgesic onset within the hour and duration of 12 hours. This is from a study that was quite a few years ago. Possible advantages over morphine included fewer hallucinations and dizziness, less nausea and vomiting, less itching, less stigma. Possibly disadvantage was more constipation. I must say I don't really believe any of that. I think I'm not a believer of all opioids are equal, but I think all opioids are equal over a population. In other words, different people tolerate different opioids differently. So that sort of cardinal rule that I spoke about is finding the right drug for that particular patient. And that gets back to this idea of opioid rotation or opioid swap. There's nothing clever about it. It's like, I guess, using drugs for hypertension. You give a patient a drug for hypertension and you say, see how you go with this. You don't know if it's going to A, be effective, or whether they're going to get side effects. They come back and say, I felt terrible on that drug. Well, you don't say, well, put up with it for the next 6 months and see how you go. You actually say, well, let's stop that. If you're a really crook and you couldn't move and you're falling over all the time, let's stop it. It's no good for you. Let's try something else. And it's the same with the opioids. There's nothing magic about it at all. So I would certainly not use oxycodone and say to someone, it's got less nausea and vomiting. I don't really believe that. Why put the slide up? Because I think it's a contentious issue. There's obviously research that's going or has gone on in the past. I would have thought that this is probably about the time that OxyContin was funding studies to be done. So oxycodone is a good and useful drug, and we all use it. Hydromorphone, perhaps. Now, can I just ask in the audience, who has used hydromorphone for their patients? Anybody? Or yes, as you would if you're going to Canossa. Anyone else used hydromorphone? No. Well, hydromorphone has been around for a long, long time. It sort of came and then it went. And then it was sort of reintroduced, I don't know, about a decade ago, I suppose. It was relaunched in oral and parenteral forms. So, as we've already discussed tonight, approximately 5 to 7.5 times as potent as morphine. Half-life is short, like the other opioids. It's currently available in both oral and parenteral forms, and as I said, we use it a lot in the syringe drivers. Current availability is immediate release tablets. So as you can see, they'd be the equivalent of 10 milligrams up of morphine. So if you had someone who was not requiring that big a breakthrough dose, well, using hydromorphone would be a bit of a challenge. Liquid, so you could certainly down titrate using the liquid, and that's available on the PBS as well. And then you've got the ampules for the drivers. And last year, the slow released preparation came along. And that's Jurnista, and I've used it on one occasion and it wasn't all that effective, but obviously I'll be using it again to see what sort of response you get with patients, particularly if they say having troubles with morphine. I think it's reasonable to give it a try and get some experience with it. So it's just the convenience is it's a once a day dose. It's got this interesting Auris push-pull technology, and basically the tablet has a very fine hole in it. And then once you get fluid into it, it gets into the tablet, and it actually, what it does, it just squeezes the hydromorphone out through the hole in a controlled release fashion.